staff, or afternoon, I guess. Just want to see if you were paying any attention or not, but apparently some folks were. So anyway, very good. Thanks to everybody for being here. Committee, I did have a couple of questions for you from yesterday for the test. One of them is, what is the annual amount of the TANF block grant that we receive every year for the TANF block grant?
I know.
Representative Clifford.
Do I have to have my mic on, or can I just whisper it?
No.
It seemed like it was 104 million.
Pretty close. $101,477,000. And the other question is, what is the amount of the tobacco settlement that we receive annually?
Which year?
Let's just go for 2021, the actual. Representative Howardin. It was $50,402,000. So you guys are close. So very good. So, well, stay tuned. We're going to have some more of these. So very good. All right. Committee, are there any bill introductions? Seeing none, we're going to start the informational hearing on nursing facility staffing. The first item I have here is Bob, and I'm not even going to try to say that last name. So, Bob, are you here? He's online. Bob, can you hear us? Anything? Okay. Well, we'll move on down to Haley. We'll come back to him in a bit. All right, very good. Thank you for being here.
Okay, thank you for having me. Again, my name is Haley Ordoin. I am here on behalf of the Kansas Adult Care Executives. We are an association that represents the administrators and operators of the senior living communities throughout the state of Kansas. And I appreciate the invite to come and present on behalf of that. So, staffing agencies, staffing shortages. I think it's no big surprise that we had staffing shortages prior to and the pandemic, and it has now amplified it. Our reimbursement rates seem to be an obstacle for us because these rates aren't there to sustain now the high pay rate that we are really obligated to pay to be able to provide the care. About 5 years ago, we used to have a case mix of about 50% private pay and 50% Medicaid in our buildings. That number no longer is anywhere accurate. We're closer to the 70-75% Medicaid occupancy in the state, and sometimes even higher. What that means is people are coming on Medicaid sooner, and our reimbursement rate through Medicaid is often set through the state with the current methodology. The current reimbursement rate is not adequate. I won't give you a lesson on rate methodology, but I'll give you some key points. It's often very antiquated because it uses the last 3-year average, not including the most recent year. Then there's an option for an increase to adjust, but oftentimes it's just an option. So really, it often seems like we're working about 5 years behind the actual cost, and the goal was always to reimburse up to 85%. Again, we're nowhere near close on that. So staffing agencies, what do we seem to experience by working through them? Oftentimes, our mileage, meals, labor rate, and hotel fees are charged an additional fee on top of the rate that we're charged to have the staff in our building. They have a buyback or buyout clause very frequently that if we want to hire someone from their agency for us, that can be anywhere from, we've seen $3,000 up to $10,000 per person. However, there's nothing in place on the reverse of that, that if they hire and recruit one of our staff when their employees are in our building, there's no penalty, there's no fee, there's no buyout to us. We're being extorted, we feel, through these staffing agencies to pay overtime when that person did not provide overtime within our building. And I put in a highlighted example of that in my testimony, that if we have a nurse work building A 20 hours, building B 20 hours, and then we're building C and they come and work 5 hours for us, we're now paying that cumulative overtime rate, even though they only worked 5 hours for us. And oftentimes, we don't know about that until we get the bill. We're not told ahead of time. Agencies hold individualized contracts, which again, we have no problem with, but the problem that we experience with that is that oftentimes they can pull staff that have committed to an assignment for us to go work in another building where they get a higher reimbursement rate, where they have a higher contract there, and that often leaves us stranded. There's no known competency expectations for these agencies. Nursing homes are inspected annually every 9 to 18, 24 months based on how our state's doing with that. But when we have those surveys, all sorts of stuff's inspected. These staffing agencies are not held to that same level of expectations that we are. There's no licensing oversight. There's no penalties for when they have staff that completes med errors or does, negligent acts. It's our responsibility when we sign on to have that staff in our building. And we do our best to try and train them on our policies, procedures, expectations, and standards. But when they're, working different building, I can see how it's very complicated and hard to remember what the expectations are in each location. More money is being paid to the daily administrative rate of an agency than what we receive in reimbursement for the state average of Medicaid. I know that was a mouthful, so I'm going to try and break that down. Say, for example, our state average for Medicaid reimbursement on a resident is $200 a day, okay? With that, we're expected to provide staffing, provide meals, provide activities of daily living, D, all of the above, okay? So we have a building. I'm in North Central Kansas. A colleague of mine had a CNA rate charged from an agency of $45 an hour. COVID's not in that building. That is not a COVID rate. That is not an emergency rate. That is a standard flat rate for this CNA. She asked the CNA, what do you get hourly out of this? The CNA gets $25 an hour. Okay. CNA gets 25, the other 20 an hour goes to that agency for their administrative cost. Average, our CNAs or nurses work 8 hours, 12 hours, go in the middle of the road of a 10-hour shift. That agency with that one person has now taken our entire reimbursement for one resident day just by having that person. So we feel like we're being held to a little bit different standards here when that reimbursement rate that we are reimbursed on average, we're expected to include all these services, and here it goes just for their administrative cost. I attempted to put some graphs because I know I'm a visual learner. I don't know if you are too. But on page 2, I have a chart there that kind of shows these are some averages of average hourly rates paid prior, these are prior to pandemic. These average agency hourly rates without COVID in our building, I would say that's not even accurate anymore. It seems to constantly be increasing, and I've seen some of the testimony that you will hear after me, and it seems like there's some pretty substantial evidence of that occurring. But even then, you're looking at close to a 250% markup of those rates. We surveyed our membership, and you can see just a few different things. Prior to the pandemic, the majority were not using agency. Now it's pretty darn close to everybody. We're being forced to. How much over your current rate are you paying your agency staff? Most of us are averaging 3 times the rate. It's not sustainable. And how much longer can we sustain that? Most of us are less than 90 days. And how many of us have lost staff to agency? About 90%. So if they say, want to make the claim that staff is not, we feel, being poached away from us by bringing agency into our buildings, it feels very much like a parasite. We have to have them in, but then they take to where we're left with our hands tied. I kind of talked a little bit, like I said, about the Medicaid rate increase. I would just kind of encourage you on your own to understand that and learn a little bit more as to why we're frequently here asking for a recalculation of the rate methodology. But the bigger picture I want to paint is the consequences of if we don't take any action of what will most likely happen. More nursing homes are going to close due to the unavailability to provide staffing. When these homes close, state receivership will take place. So if a nursing facility closes and the state has to step in, there's a CMP fund set aside for these instances. I know a couple years ago, if some of you were on the Bethel committee, you saw where I think the state acquired 22 nursing homes. That fund goes to operate that. That fund has about $5 million in it right now. That will dwindle very quickly. Very, very quickly if we have an existence of nursing homes that close due to not being able to provide staffing. The National Guard is already being deployed in many states, and I wouldn't be surprised if we get that to that point here too. Rural communities will obviously deteriorate, which is a big majority of what our state is made up of. Families will now have to drive 1 to 2 hours to see their loved ones, and that's conservative. Ultimately, everyone will be paying more. The state will be paying more too because we will have more people going on Medicaid as these years come about. The more that we are paying in staffing, the less money that's actually going to the resident care, which is what it should all be about. So a couple solutions that we propose or request. If we know that there's current legislation that was referred to the Committee on Children and Seniors that holds language for agency oversight that we are very much in support of. That is House Bill 2524, and it's set for a hearing next Tuesday. That contains a lot of guidance for inspections, rate caps, penalties, and liability to even the field with all healthcare providers and the agencies. We saw that, and we thank you if any of you had a part in this, for extending the temporary nurse aid program out. That has been a lifeline that many of us have used, and we hope to make that a permanent pathway for a career ladder. Again, we would ask for a cap with the rate that agencies can charge. A lot of states that have imposed this already are capping that at 150% of the median wage rate average. Eliminate the non-compete buyout clause that agencies enforce, invoke stricter regulations and oversight of these agencies, and hold them accountable and to the same standards as the environment that we serve, and review the Medicaid reimbursement rate methodology so that it can acclimate to the actual costs of the services provided so that we can keep caring for the wonderful seniors in our state. So I thank you for your time and attention, and I'm happy to stand for questions at the appropriate time.
Any questions? Representative Reeves.
I just wanted to indicate that Bob Livonius is on, and I apologize.
Okay, we'll catch up with you here in a bit.
Thank you.
Thank you, Mr. Chair. I'm just wanting to make sure I have this right. On House Bill 2524, will that put the cap on the rate of the staffing agencies? Is that?
Yes, my understanding is yes, of that at 150%.
Okay. Thank you. Thank you, Mr. Chair.
Representative Lynn.
Thank you, Mr. Chair. So when you go into a contract with a staffing agency, what is actually a part of their contract?
A lot of the time, it really just spells out the basics of here's the rate that we will charge you for providing your staff. Providing the staffing, it's really just a graph of that. And then there's also clauses in there on our behalf too of buyout fees. And then also if we were to cancel the staff, call off them, we are charged a rate of that also too. And a lot of it's the financials spelled out. We don't receive copies of liabilities, of insurances, of competency testing, or any of those sort of things.
So, if I may, are they responsible for providing anything? Are they ever in breach of their contract?
I guess I'm sorry, can you clarify a little bit more of, are they in breach of their contract for?
Well, if they're not providing the services, if they don't have to always, they're sending you someone who's on overtime. Does it spell out in their contract that they won't do that, or they won't charge you for that overtime? Or if they don't have anybody to send you, they can't guarantee a certain price?
It basically, they state that these are the fees that we will charge, and you would be notified of an increase.
But you don't even get notified if it's somebody who's overtime until you're charged for it.
Right, and then oftentimes it's our business office contacting and asking why there's a discrepancy.
Thank you, Mr. Chair.
Representative Clifford.
Thank you, Mr. Chairman. How nimble are your facilities? I represent far frontier Kansas against Colorado border with many facilities. You're in a micro environment with people who are geographically placed and not going to go to Kansas City to work. So when that person's being poached, can you offer them that $25 an hour to keep them there, or what happens?
The difficulty with that is all about sustainability. I know a lot of, like, the hospitals received funding to have these, give these great bonuses and do these rate increases. Ours is, we're capped at what we can sustain and how long we can do that. So some of us have tried to undercut the staffing agencies, because at this point we're trying to do anything we can and offer those wages, but it seems to be a ripple effect. If we have one over here that negotiates this contract, then this wage, then a lot of times it's a ripple effect and all of our staff is doing it, and before long we are paying out more in wages than what we're even bringing in on a daily basis, and that's where we become non-sustainable.
So it's a whack-a-mole game.
Yes. Every day.
Committee, further questions? Representative Lynn.
Thank you, Mr. Chair. It's not necessarily for Haley, but I'm curious to know that when the National Guard is employed, how much that costs the state? I don't know if there's anybody that could answer that at some point for us.
The state of Minnesota probably could.
That's it. Thank you, Mr. Chair.
Very good. Thank you. I have no idea what that would.
Thank you.
Thank you very much for being here. Okay, Bob, are you there?
Yes, I am, sir. Sorry, I couldn't get my video to work. Can you hear me okay?
We can hear you.
Okay. Would you like me to go ahead?
Please.
Okay, great. I did send some materials out there, and I want to thank you for letting me participate, providing the committee some insight into the staffing industry. It's been in existence for about 65 years. I'd like to address, what is really driving up the cost of temporary nurses during this pandemic, and what I hope would be the real solution. I've been in the industry about 30 years. I've run several large healthcare staffing companies. I'm still on the board of several today, and I'm actively involved with the American Staffing Association to help educate and communicate on behalf of about 5,000 agencies in the United States that provide contract staffing to nursing homes and hospitals and other facilities. It's become a very common talking point, and I think the previous testimony spoke to the $25 an hour and $45 an hour. First of all, that $25 an hour example probably should, the rates on that $25 an hour, $45 is pretty extraordinary. And it does sound like that in your particular market or in market that those rates are higher than what I've seen elsewhere. But normally what agencies are taking is what you would hear is you hear 40% of the pay rate increase as a profits. Well, the correct number is about 7 to 12% is the actual profit. And then we can testify that with, or we can support that with studies that show what the averages are. I've included a handout in your material from the American Staffing Association that explains a little bit about the higher pay rates that are driving the nursing costs, and this discusses some of the imbalances in supply. And we do predict that the inflationary pressures will moderate as the pandemic subsides. But unfortunately, the nursing shortage is going to remain. We are going to have a problem. I think I want to highlight that most of the current data shows that the gross profits of staffing agencies are actually down, not up. And I'll explain how that's the case. And that this rumor that we're passing the increases along and not passing them along to the nurses, that's really exactly the opposite. The nurses have been increasing their pay rates as a result of unprecedented nursing shortage. The bill rates have gone up at a slower pace, actually, than the increasing wages. So I'll give you a deeper insight into how an agency works and kind of clarify some misperceptions and maybe some pricing, some claims around price gouging. And later, I hope you'll allow me to answer any questions. As a background, there are 3 million nurses in the United States. Keep this in mind, only 2% of those work for staffing agencies. Only about 6% of all RNs work in long-term care. So it's a very small population. Of course, long-term nursing homes really rely upon certified nursing assistants. There are about 1.6 million CNAs in the United States, and the average annual salary is about $30,000. That's well below what it needs to be in order to attract and retain CNAs. That's the core of the problem. When Walmart and Amazon can provide more money to these people, we have a real shortage problem. Only about 600,000 work in nursing homes, and about 3 to 5% of those actually work for staffing agencies. So when you're talking about this population of all these staff that's out there that are working for staffing agencies, it really only still represents somewhere between 3 and 5% of the total workforce. And that means it's 3 to 5% of the total problem. But it's getting worse. It's definitely getting worse. The number of CNAs working agencies is much smaller than you think. So a lot of them you think are working full-time jobs, and they're just picking up for extra hours. So I know that 60 to 70% of the CNAs that are working today are working full-time positions. And when you're talking about your CNAs getting poached away, they are typically going to work for an agency to work extra hours, and then typically still work for the same agency. They don't leave the facility. They go to work for extra hours typically. That's about 70% of what the data shows. So there are situations where nurses can be attracted away for personal reasons, or they might go to work for another facility. But they use this agency as a way to gap their income requirements. And staffing agencies actually are a facilitator of keeping nurses working in nursing. Without staffing agencies, we'd have even fewer nurses willing to work. There is a big problem in filling open orders today for nursing homes, assisted living facilities as well. The Bureau of Labor Statistics said that during this pandemic, that the nursing home industry has lost 420,000 jobs. That's reduced the workforce to what it was 15 years ago. That's the core of the problem we have. And the primary reasons are the fear of COVID, the fear of the vaccine. The client has restricted the use of agencies, or the exhaustion and stress of the job compared to wages at Amazon or at Walmart. It's exacerbated the existing nursing shortage that we already have. And the pre-COVID demand was growing faster than any other job category. The number one growth requirement in jobs in the United States is medical assistants, or essentially CNAs. The expected growth is about 9%. Recent study in Florida said that 6 people are leaving the profession for every 1 new certified nurse. So the problem is that the gap is getting even larger, and staffing agencies are a part of helping keep those nurses in place. let me explain why the profit margins for staffing agencies are only 7 to 12 cents on the dollar. This idea that we are price gouging and significantly profiting is just factually not true. Staffing agencies are employers of record of their nurses. So when they're on assignment, you talked about, what obligations we have. We're the same obligations you have as an employer. We basically are responsible to carry and pay all professional liability insurance, to cover any clinical errors. We're responsible for paying workers' compensation insurance for any injuries on the job. We pay unemployment claims. We pay all payroll taxes, including federal and state taxes. We're obligated to pay overtime. We provide drug testing, skills testing, background checks, all at our cost. We're responsible for contacting the state to ensure that the compliance of all the nurses is properly licensed and verified with all the documentation. And the former testimony talked about how there's no accountability around that. Well, there is. You simply request the information from your staffing agency. They're obligated to provide all the credentials, and they have to have all the credentials on site. Almost all of the good staffing agencies are JACO certified, and JACO requires all of those things to take place. So if you're not, and I did do another handout where I put the 5 things to look for. Well, I wouldn't use a staffing agency that isn't JACO certified. I'd probably steer away from them. I certainly would use not a staffing agency that's not an employer of their people. If they're using independent contractors, they're actually somebody we should report to the Department of Labor. That's illegal to do. So when we start to see some of those actions taking place, I could see some frustration on the part of clients, but that's not the norm. That's the problem. Top of these costs for recruitment and onboarding staff, the advertising costs to get the right qualified candidates, and then there's always the cost of the office staff, the coordinating, rescheduling, call-off, sickness, the final placement at the right place at the right time. It's interesting to note that about 15 to 20% of shifts that are filled with people who are ready to go are canceled by the client before they start. So that's just rework on the part of the agencies. We also fund the payroll for the clients. So agencies pay their nurses every week, but we don't get paid for every 30 to 45 days. So in some cases, long-term care facility goes out of business. We have to write off hundreds of thousands of dollars sometimes. These costs are in addition to the hourly wage that we pay, the profitability of the industry. For all recruitment, placement, and statutory costs I spoke about is an average of about 7 to 12%. So about 7 to 12 cents of every dollar goes to the bottom line of these agencies. The staffing agency serves a very important role in keeping the caregivers in the health care as possible by enabling them to work just the number of hours they want to work and keeping them active in the workforce. I know that one of the frustrations of the caps on Medicare and Medicaid, as the previous testimony talked about, these caps must allow for higher wage rates for nurses. If we were paying other nurses more money as a result of higher caps, we wouldn't have nearly the number of people leaving the industry. We wouldn't have as much need for staffing agencies, and certainly the rates would be lower. The pandemic has really exposed this for every facility and every administrator across the country. So we are sympathetic to it. We're actually hopeful that we can get these rates down. This is what these nurses are demanding in order to do this kind of work. I'm going to kind of skip forward because I've got some more testimony in there, but I want to try to shorten it up. So I want to just talk about the fact that there's competition between the agencies. As you know, and I don't know, in some of the rural markets or some of the harder markets, maybe that's a problem. We don't have enough agencies there for you to compare notes with, but I strongly encourage you to find that not all agencies should be charging those, all of the higher rates. Some of them will have lower rates, and you should always compare that. And some are paying higher rates to get nurses. So the competition between the various agencies is strong, and you should make sure that you take advantage of that. I don't think there's a price gouging problem. We don't think there's a price gouging problem with agencies. It's just a function of the rates of supply and demand, and that agencies are proportionally raising the rates and not taking profits unfairly. Putting caps on staffing agencies for long-term care or in hospitals will only make things worse. Staffing agencies will not be able to pay competitive market wages. Nurses will be forced to leave Kansas and work in other states. So if you put caps on Kansas, you'll see what happened in Minnesota. The same thing happened in Massachusetts. They had an even greater shortage of workers who simply went to other states to work, or they left the profession, went to work for Walmart or went to work for Amazon. Because when you start forcing down the rates on nurses, the worst thing we can do, just the opposite of what needs to happen, is we need to be paying the nurses more, not less. So without staffing agencies, there's no easy outlet for these workers to earn the extra money. Without the agencies, the nurses who are semi-retired would be able to come back into shifts, and they're desperately needed in healthcare. We're in a labor crisis, and I know the federal and state government has stepped in, and as the last testimony just said, they did a lot to help the hospitals to pay the nurses more and gave them bonuses. This didn't happen in long-term care, and that's really a challenge. And so I empathize with the challenge that the committee faces. We don't think the staffing agencies to be capped is the answer. We've seen what's happened in Minnesota and Massachusetts. They have had to raise their cap. They had caps. They had to abandon them because they couldn't get enough people to fill the orders.
Okay.
Well, thank you. I'll be glad to take questions. Thank you.
All right. Very good. Thank you, Bob. Questions, committee? Representative Ballard.
Thank you, Mr. Chairman. Mr. Livonius, and looking at this, and I'm not sure, who do you represent, please?
Okay, so the American Staffing Association, I'm actually was a former chairman of the association, and I'm working with them. So the American Staffing Association represents all the staffing agencies across the United States.
Okay, if I understand you correctly, you're saying that nurses are justified in that they should be paid more.
Yes, absolutely. Yeah, the problem in particular in the CNA world is that the certified nursing assistant pay rates are so low, that it just can't attract, and we can't retain them enough for the population growth that we're having in the United States and the aging population. So yes, in general, they're not being paid enough at the core level.
Okay, often I hear the comparison between working at Amazon, a Walmart,
Right.
in different places. But how can, especially nonprofit organizations, keep pace with stores that really garner their profits, and that's how they're able to pay them?
Right, it's tough. And I think what you're saying is, how do you compete with a Walmart? And the answer is that I think we've underfunded, and in the Medicaid area, I think we've underfunded what the costs of labor are in today's marketplace. Today's marketplace demands higher labor costs, and it's keeping people from joining the industry.
All right, thank you. Thank you, Mr. Chairman.
Welcome, thank you.
Any further questions? Representative Rees.
Hello, this is Representative Susan Reese, and I'm going through your written testimony. So if I understand correctly, you are helping to educate and communicate on behalf of nearly 5,000 agencies in the U.S. Is that correct?
That's right.
Okay. So, so in Kansas, we're looking at House Bill 2524, which I'm sure you're aware of, that's going to add some language about agency oversight, correct?
Yes, ma'am.
Okay. So I don't know how many states have gone through this to set some kind of oversight in their language, and so and you're also saying that doing something like that would make it much more difficult for staffing agencies to hire their nurses, and then in turn being able for those nurses then to work in long-term care. Have you seen how many states have actually put these oversights, language oversights, and you've seen adverse reactions from other states? Do you have a comparison with that?
I do. So the only two states that have had caps put in place are Minnesota and Massachusetts. And both states during the pandemic had to pretty much abandon their rate caps because they weren't able to fill the needs. So while they did have rate caps in place during this pandemic period, well, before the pandemic, many of the staffing agencies in those states, they slowed down the number of staffing agencies that were there. The number of people that worked in staffing agencies was reduced because they went back to working either at the hospital or went to Amazon or someplace else. So they had a significant shortage of workers. That took place. During the pandemic, in order to try to fill the orders, they had to raise the caps or waive the caps. So their caps that they've had in place have been set aside during this very difficult time that we're having right now with the still the pandemic.
Okay, thank you.
Sure.
Any further questions? Representative Lynn.
Thank you, Mr. Chair. When you hire, let's say, an RN, do they get to choose where they go, or do you tell them where you need them?
It's really the former. Almost all nurses tell us where they'd like to work, but we also offer them opportunities to work in various places and give them the choice. So no, they're not in any way obligated to go where we tell them. They go where they want to go.
Okay, thank you, Mr. Chair.
Sure.
Any further questions? Bob, I have a few. Who regulates you?
So we, as an industry, we're regulated. There's an oversight that you can go to. And that's the Joint Commission. Are you familiar? Joint Commission certification. That's what hospitals go through. Nursing homes can go through them. It's a certification process that ensures that what you're doing is proper in every regard. That's self-administered, and you are certified if you do it, if you sign up for it. Agencies who don't do that typically aren't agencies that are either too new to do it, or they just don't think it's important enough, and I would use one of those agencies. Otherwise, the regulations of the industry are the same ones you'd have, with the IRS or with, workers' compensation with the state, or professional liability insurance coverage and those type of things. But there is no other regulation for the industry.
So you're self-regulated, is that what you're telling me?
Yes. I think that's fair to say.
We didn't hear your response, other than that's fair to say.
Yeah, yes, sir. That is fair to say.
Okay. All right. Well, Bob, you've been very generous on offering the information on those wages for our committee, and we would just love to take you up on that information. If you would please send us out some wage sheets and kind of some stuff that we can look at ourselves to kind of draw our own conclusions on how much you pay and how much these folks are telling us that you pay. Can you do that for us?
Yes, sir.
And maybe could you help us out with some other states too, not just Kansas?
Yeah, I think we can get some. I think we can get some rates for multiple states around the area.
That would be very good. So you're telling us really that these folks that we just heard testimony about are just bad actors in your in the.
No, I don't think so. I mean, I was surprised at the $25 pay rate on a $45 bill rate. I hope that's and actually the testimony said that there were some other rates that she had seen. I'd love to see those. I didn't get a chance to, but no, I don't think they're bad actors. I think that the question is that what is the nurse really obligated to pay, or what are we obligated to pay the nurse in order to get her or him to work, and then what's a fair markup on top of that? And what I'm advocating is the fact that yes, probably a 40% markup or so is about right. Because what that 40 to 50%, because then by the time you're done paying all the extra costs, you're down to something around 10 cents on the dollar in terms of profits.
So if they're making more than that, then they are bad actors. Is that what I'm hearing you say?
Yeah, I would say that here's the thing. If you're a price gouging, what price gouging really is that you are paying, your gross margins are increasing during this period. And so if I was normally making a 25% gross profit between what I pay the nurse and what I charge the client and all of the costs that I have with the nurse, if I'm making 25% pre-pandemic and in the pandemic period I'm making 35%, then that's not good. That's not right. What I think you'll find is if you look at the public companies like AMN or across country, people who do business in this sector that are publicly traded, you're going to see that their margins actually went down during this period. That they actually took less of a margin than they had previously. So I do think that there are some outliers to that, and there probably are some that are benefiting more than others. But what I'd like to encourage people to do is seek competition. I mean, call other agencies, talk to other agencies to try to see if you can't get better prices, because they compete with each other.
Very good. Also, there was an issue about overtime. So if someone's working 20 hours one place, 20 at the other, and then they're not aware of it, but they end up being the 45 hours, so they're 5 hours overtime. Is that common in your business?
No, it's actually two things. One is the only reason that would ever happen is if you were so desperate that you couldn't get a nurse and they'd already worked the 40 hours for the agency somewhere else, and that was the only nurse they had left, and they gave you the option of doing it and gave you the option of paying it. They should never do that and then tell you later that they're being charged that. That's just poor, either on the part of the nursing home, it's poor for not asking or not understanding or not properly communicating that to the administrator, or it's the agency that's not properly communicating. But that's not normal, and it's very rare. I know that I know I've heard this testimony before, and I went back and checked it out. We just don't see, nurses need to, when they work for agencies, they typically 70% of the time, they're working full-time from somebody else. So their overtime is coming from the agency, but it's not being paid as overtime because they're working for a different employer and they're working at a different facility. So it's the bottom line of that, that's a rare thing. And it's not common. It shouldn't happen.
Okay. Well, very good. Well, thank you for your testimony, and I look forward to that information. You can certainly email it to, we have your contact information. I think you have a committee's contact information. You can certainly email that to me. I look forward to seeing that. I think I was just on the internet, and I Googled a little deal here. It says House investigates price gouging from staffing agencies. This is a congressional House. 200 members of Congress have signed a statement nationwide calling for White House officials to investigate nursing staffing agencies' conduct over the course of the pandemic. So I think what happens on these situations is when people do abuse the situation and take advantage of a bad situation, I think that's how we end up getting the regulations that we all hate. And I have struggled with this because I am a free market guy, but I've got to tell you that I'm running out of patience with these egregious acts from these staffing agencies. So, Bob, I hope you can dispel all of my bad feelings and about that and about how things are transpiring in the staffing agency, and that prove me wrong. That's what I would say. So, very good. Thank you for your testimony. And okay, next we have Anthony Johnson. Is your microphone on? Yeah, there you go. Thank you.
It's great to be here. Thank you very much. I'm coming off pneumonia, but I felt so passionately about this testimony today that I wanted to be here and speak to you. I'm the Chief Operating Officer for Recover Care. We operate 20 buildings and 1 hospital in the state of Kansas. I've been working with this same group of facilities for 8 years now. And I'm also the Vice President of Government Affairs for KHCA. So I'm going to speak today on behalf of our members and what I've seen in our operations during the last year or so. I kind of go off script, but you have my outline and points. You know, it's very clear. Everybody has said how challenging it is in the workforce right now. We see it everywhere. Obviously, we don't have the ability to close early if we don't have the staff. The agencies know that. We can't be like Burger King and close at 7. We've been in this crisis for 2 years. You know, the awful tornadoes that went through Kentucky a couple months ago, if Home Depot and Lowe's decided to quadruple or triple their cost of goods to repair damaged homes, that would get a lot of attention, a lot of outrage. I believe fully, and I think I have some evidence to support the fact that the agencies in Kansas, at least, aren't letting a crisis go to waste. With the agencies, prior to the pandemic, agencies were not desirable due to the cost. Sometimes the quality of the employees themselves. They can't find a stable job. They've been kind of transient. No provider in this state wants an agency employee in their building. You get inconsistent care, quality issues, and it's starting to be evident that agencies are becoming a de facto collective bargaining unit. And to support that claim, I have a video that I'd like to play.
I don't know what healthcare worker needs to hear this, but listen, if you haven't noticed this mass exodus of everybody quitting their full-time jobs and walking out the hospitals, walking out the nursing homes, agency is the new union. We get to negotiate our pay, tell them when we feel like we can come in, get paid the same day or at least that week, and we get paid more money. And we don't work for none of these people. You can walk out. You walk into a place and you don't like what's going on. It feels funny. Nah, I'm good. Bye. And you can still go to work the next day. Heck, you can go to work the same day. You have full control over you. Full agency over you. Damn that full-time job. Quit. Put your 2-week notice in today. Find you an agency. Agency is the new union.
In my 8 years here, we've done several wage increases, and I've seen a pattern. Obviously, I've had some buildings prior to the pandemic in agency. We would put together a thoughtful plan and raise rates as much as we could afford. I've seen it happen in the 8 years. The agencies find out what we're paying. They leapfrog what we're paying to poach our employees so they can bill them back to us at a premium. So I think I speak for my association, my peers, and myself. I agree. Healthcare workers work very hard and should be paid a fair wage to live on. But at this rate that we're going, there's going to be less access or less providers because we can't keep up with these increases at these rates. we can't raise prices like Walmart or Amazon. 75% of our revenues are coming from Medicaid. And then ultimately, as you all know, the Medicaid caps will be increased and will capture some of the costs back. But the problem is there's an 18-month gap, and some providers won't make it to when the cost reports capture this. And it's going to cost all of us taxpayers money. Our organization has spent $9.8 million on agency through November of this year. The agency staff can be unreliable. In attachments, I showed some actual invoices from some of the agencies in Kansas, and I don't see them touting anywhere that they're JACO accredited, by the way. And you'll notice some of the language in there. Exhibit A, they've gone to these tiers, and they never charge the base anymore because it's always a crisis. For example, their own employee will call in, last minute always, and then they'll say, well, we could probably fill it if you'll go up a tier. They'll put you in priority. And so, I'm not a dumb guy, but who's to say that they're not rigging the game with their own call-ins? They could send this nurse down the road, nobody would know, and then they send me another one with a premium rate, because what are we going to do? We need people. It's extortion. Exhibit B from Zach Group.
And Anthony, could you kind of move it along a little bit? We've got some other people to testify, and I don't want to be here by myself tonight. So,
Certainly, I can speed it up real quick.
thank you. I know this committee well.
Okay. All right, they can increase their rates at any time, and they do it. And if you look at the invoices from Christmas, this is for one facility. We spent $122,000 to staff Christmas. The information is in there, and I encourage you to look at the language where they say they can raise our rates at any point. We are totally beholden to them because we need to provide care. So that concludes my testimony, and I'll open it up to any questions you may have.
Committee questions. Representative Lynn.
Thank you, Mr. Chair. Typically, when you lose someone to an agency, do they tend to stay local? Do they move out of state? Do you see them again at your facility?
Typically, we can see them back in our facility. That's if we allow it. I know some providers will say, you can't work in my facility for a year, but I hear that happening less and less.
Where do they typically go? They stay local?
I think it depends on where they are or where they are in life. I know some young people want to be a traveling nurse and hang out in Colorado. That's attractive to some people, but I can only guess what percentage do that.
Thank you, Mr. Chair.
Any further questions?
Yeah.
Representative Ballard.
Thank you. I was looking when you say our staffing agreement rate states that we can increase our rates at any time.
Mm-hmm.
Okay, so that's within the agency.
Yes.
Okay, under what circumstances would you increase the rate if you were paying X amount of dollars at this point? What would cause you to increase that rate? That day, that week, or would you give them notice?
Oh, they give me the notice when they want of when they're going to increase.
Okay, so that's the agency.
Yeah, and in one of the packets, there's an email letter that, you know, because Omicron was going on, they decided to do a COVID rate all the time.
Okay, now I understand. So really, that's their cover. That's their cover because it's right here, and if you agree to it, then you become very vulnerable at that point, and you can't come back and do anything about it.
Correct.
Okay,
And that's where we feel powerless. We're at their mercy.
and you are powerless. Because you have people that you have to take care of, and you're licensed to do just that. Thank you very much. Thank you, Mr. Chairman.
Committee, further questions? If we could go through your testimony here on, it's this MedStar Healthcare Staffing LLC. Do you have a copy of this? It's page, it's after exhibit, but it's the one, it's 3 from the back. I just wanted to, MedStar Healthcare Staffing Agency invoice to Meadowlark Rehabilitation Hospital. Okay, so this is $50 an hour for a CNA.
Correct.
Okay. And $80 an hour for an RN on the day shift.
Correct.
And another $50 LPN. I don't know what NOC means. Night
Yeah.
shift. Okay.
Thank you.
$225, is that an hour?
Correct.
An LPN, day shift, hospital, triple time offered? So what would be a scenario that would happen? You just had to have someone and you paid triple time?
Yes.
Oh, Christmas, I see. Yeah, I see the dates now, duh. Sorry. Okay. Wow.
In prior years, the routine and customary would be time and a half, not triple.
Right. And so then over on the next, that's so it's 21,000, like you said, for Christmas Eve. Wow, and Christmas Day. Then over here we got Healthcare Solutions. So these are for 12-hour shifts?
Correct.
Okay. So an RN for a 12-hour shift is that $4,000 for that 9.5 hours? Is that what I'm seeing?
Yes.
Wow. So there's another one down there for a CNN for 12 hours at $150 an hour.
Correct.
Well, Bob, are you still on the phone, on the deal? Apparently he's gone.
Yes, sir, I am.
Bob, are you still on there?
Yes, sir. Can you hear me?
Yes, we can hear you. Bob, well, I'm looking at an invoice from one of a staffing agency. I'm looking at a rate here of 9.5 hours at $450 an hour for an RN. Would you consider that a bad actor in your organization?
I don't know what we're paying the nurse, but I don't know why it would be that high. I don't know why that would be that high unless this nurse is working on an overtime basis, but I don't know why it would be that high.
We have CNAs here making $150 an hour. If that's realistic, that would be a bad actor. Is that what I would hear?
Yeah, the only thing I'd ask is what are we paying the nurse in those cases? if it's $150 an hour and they're making a 25% markup because they're having to get the nurse for $100 an hour, then it's not. But if they're not paying the nurse $100 an hour, then they are abusing it.
Are you aware of any of those rates being that high?
That seems, yeah, for CNA, that seems awfully high. Unless, are these travelers that are coming in from out of state that you're paying the travel rates as well?
No, they're local agencies.
Well, I think that's alarming, even probably for you, Bob. Wow. Okay, committee, further questions? Well, Bob, thank you for answering that question. Maybe we could trade exhibits here. When you send me some stuff, I'll send you this stuff, and we can kind of come to some kind of a deal. Would that be okay?
Sure.
Okay, very good. Thank you.
Thank you.
All right. Next, we have Kelly Summers, State Director, Kansas Nursing Association. Thank you very much for being here.
Thank you, Mr. Chair, for allowing me to speak today. I honestly didn't know what the conversation was going to be, so please bear with me on this. I hope I get a little bit of the time because it seems to be that we're talking a lot about staffing, but you're not hearing from staff. And I think it's just really important at this time that that's who you're hearing from too, regarding pay, why your nurses are leaving, and that type of issue right now. So hopefully I could explain some of it and answer your questions. But I will say, you know, Bob was right regarding a lot of pieces when it relates to nursing right now too, when it comes to pay. When I was looking at, I think it was cases breakdown of how much they would pay, let's say a registered nurse or an LPN or a CNA, that's extremely low pre-COVID. Kansas pre-COVID was in the bottom 5 states for how much we paid a registered nurse. There has always been turnover in long-term care. This is nothing new. But what's happened during COVID is that you're seeing agencies, you're seeing travel nursing, you're seeing hospitals. Yes, they're able to compete, and that's not something I'm here to solve, but what I am saying is that absolutely a registered nurse is going to go where they feel valued and where they're getting paid and compensated for what they deserve. This is a license that they have paid for. A registered nurse has to be accepted in a program, has to go through hours and hours of training a week outside of class time, and then to get a license, sustain their license by doing continuing education credits. And now what we're seeing is that they're working long shifts. They're absolutely exhausted. Their mental capacity right now is far beyond a breaking point. And so they're going to go to agencies right now because, as Bob pointed out, they can choose when it is that they work. And why can't they have the choice right now if they cannot take it anymore? We're lucky that we still have the option right now to hire a registered nurse through an agency. I understand the need for regulation. I never want anyone to think that I haven't had conversations regarding regulation. However, I would say it's not poaching a registered nurse. It's giving a registered nurse an option that already existed a long time ago. And so this isn't anything new. Registered nurses knew about it prior. They just know that these options are going to fit them better during an age of COVID where they haven't had a break right now. There's other reasons that I listed too, because I think that it's important on those papers. Sorry, I talked about multitude of things because I didn't know what was going to be discussed. And I'm always happy to provide additional documentation. But I put on there part of the reasons for leaving. And sorry, let me get to my page, and I have a lot. So, but I think we can easily say I've talked about overworked, I've talked about exhausted, I've talked about mental health, putting your license at risk. Those nurses are putting their license on the line right now, signing documents they shouldn't be signing, that are tasks performed by somebody else. And I get this information from nurses who have recently left the industry of long-term care. And this is not supposition on my point whatsoever. So when you're signing documents, that's your nursing license and you could lose it. And they have every right to leave or to refuse to sign documentation. Another reason is lack of transparency from administration and really lack of communication. It's a lot of top-down communication. It's happening on long-term care level. It's happening in hospitals. And I hear it every single day, all day long regarding this. Nothing new, but it's been exacerbated. And I think this is an example right here is that we're the largest nursing association in the state, and we're constituent members of ANA, the largest in the country. I talk to our states all over the United States about what's going on with staffing, but yet for some reason, and yes, I'm outspoken, but you better bring nurses to the table for the discussions and quit having just these conversations with those who own and have a different vested interest. And so I would say that also. And then some of them have reported to me poor care of seniors. I think when we see that we have about 169 that are currently, I don't know if you would call it under investigation. Sorry, I can look real quick, but that are out of compliance. So we have 169 facilities that are out of compliance. So we haven't been able to train CNAs, part of their education in the long-term care facilities. Part of that could be the 169. It could also be the reason because of COVID. Though, I'm sorry, but when you're seeing this TNA, though I prefer to call it a TA position, when you're seeing this position out there right now, for me and for everyone that I have spoken to within our association is, why aren't you opening your doors to these students that have more hours of education to come in there, finish their education, versus a TNA position that is probably practicing way outside of what they're supposed to be doing. I'm waiting to get information from KDADS regarding that also, because there still is a lack of transparency with all of this. And then it is salary that I mentioned earlier. And I am never going to fault a nurse for going to work for an agency. I'm never going to fault a nurse for going to work for and do travel nursing. It's always been there and has really fit a need. And I can give myself as an example. I have worked in institutionalized care, not long-term care, institutionalized care. And we have had agency nurses that have come in to cover shifts. And I'll tell you what would have happened. If I wouldn't have had an agency nurse come in and cover my shift, I would have never been allowed to leave, because it would be considered abandoning my job. So as long as I am there and there's no nurse to come in and take my place, I have to stay. Period. So we really need those agency nurses. So, I mean, I hope that gives a little bit of insight into it. I'm always happy to talk more about staffing right now because it's such a critical issue, and there just needs to be more conversations with our nurses. They're so frustrated and upset right now. And, you know, if you spend your day listening to all of the sad stories, to listen to all the crying, and I'll get teary because this is something I do every day, all day long. And when you were talking about your area, Southwest Kansas, you guys are hurting poorly. I know nurses who work in your area. I know nurses who work in hospitals down there. And I sat there for an hour and a half 2 weeks ago and had a call with a nurse and what was going on down there. And so I greatly empathize with your area because I think your area has been hit hard and heavy right now. And so I greatly empathize with you. And I'm sorry that you're going through that down there, and I'm sorry for everyone. So, would anyone like to ask any questions?
Of course.
Yeah.
Just for the record, this isn't about nurses. They are heroes as far as I'm concerned. They
Well,
have
and
done.
CNAs too.
And CNAs, any frontline worker, through this mess that we call a pandemic. So I don't think that's what we're aiming at here.
Right.
But we are aiming at people that are taking advantage. I don't believe that there's any nurse getting paid $450 an hour. What do you think?
No.
Okay.
I'd leave my job for that. No, I'm kidding.
Okay, and that's, I think so we are not attacking nurses, so let's just make that very
Right,
clear
right.
here.
No,
Okay.
no, I know you're
Okay.
not. Thank
We're
you.
just trying to get to the bottom of a staffing issue problem, and we've got contracts here that say that they were billed
Right.
$450 an hour for a nurse.
No, they do not get that amount of money. And I honestly, the rates that they're getting now, when I look at this, when I've worked with agency nurses in the past, according to what they're paying here, that was in, I'm trying to remember whose document, cases, information, that's still higher than what they've gotten paid in the past, in their document too, than those who come from agencies.
Okay. very
Also.
good. Questions? Representative Ballard.
Yes.
Thank you, Mr. Chairman. I will say a very similar thing because, I mean, the way you were talking, it was like we were attacking nurses. No, we're not.
No, I don't feel that way at all.
We're not doing it, you know, and I would
No.
look at that, you know, because my mother was a nurse. She since passed away, and she loved the 11 to 7 shift. And she worked that 11 to 7 shift because she was there when we came home from school, or she could pick us up. And we could do a dinner. That's how I learned to cook, you know, because I was helping her do it. Then she left the house at 10:15, so she was at 11 shift. She got off at 7, and she was back by the time, you know, she got there. So I
Bless her
understand it.
heart.
And I think my mother would really smile when she said, now nurses can kind of demand a little more respect. They can go places. She never traveled. She did just that. So I have no problem with that. What we're talking about, though, is the agency then gets it. So there's a lot of money being paid out, but the nurse is not getting it.
No,
See, that-
that's my concern though, that with regulation, how you hold them to account without penalizing the nurse.
Yeah, but see, that's the issue.
Yeah.
But because somebody is making a lot of money, now maybe the nurse is making more than they had made before, and that's a good thing. I have no problem with that whatsoever. But to use that person, that individual, in order for you to make your profits on it, should there be some kind of, we can't cap, we don't have that kind of responsibility, but we can call them out on it because it is making nurses look bad. It is making a lot of people look bad because they're not getting the money, but they do have the option. They can make the choice, and they deserve to do it because they've gotten the license and the training.
Right.
So, but I want to make sure that it's not the nurses.
Oh, I know. I
We're
completely
worried about
understand.
the
Yes.
other people.
Right.
And they have a right to make a little bit too, because if you have a business, you get a profit. But to me, how much profit are you getting? Are you running nonprofit out of business? Are you running other people out of business? Or are we desperate and you come to me and I have no options? Well, you back somebody in a corner, they're going to come out fighting.
Oh, absolutely. And I totally agree. I've read all of this and I have conversations in the media, and I have had conversations with the Kansas Hospital Association on this because those rates are astronomical, and it is hurting nurses because, you know, what you read about in, let's say, the media is something completely opposite of what it is from a nurse's point of view.
Sure you didn't
No,
with that opinion, because I wouldn't anybody say that.
absolutely not.
Representative Ballard was sitting there and she going after nurses. Oh, she was not. And none of us were doing that. We were protecting them. And actually, believe it, we are protecting them even more than they think they are, because we don't want them to be exploited.
Right,
All right.
exactly. I did
Mr. Chairman, I'm
talk
done.
about- I'm sorry, and
Committee, further
Mr. Chair.
questions? Very good. Thank you again.
Thank you so much for the opportunity, and I was also just trying to explain a couple reasons why they're leaving, so that we can also start taking a look at those issues too. So I hope that was a little bit helpful, and I really appreciate the opportunity to speak to you today. And yes, I did not take offense to anything that was said, nothing that was said today.
Very good. Thank you again.
Thank you.
Okay, committee, further. Okay, committee, we will start Monday with our real job, which is, we've been messing around, loafing around. Remember my new word? We've been loafing around. But we will start budget hearings on Monday. So I don't remember who it was, who we're hearing Monday, but okay, so we're going to hear 3 budgets on Monday, and then we'll do recommendations this week. And, yeah, we're saving the others. So anyway, with that, we're adjourned. Thank you.